Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into the podcast. It's always nice to have you here. I'm about to get into more material on testosterone replacement therapy in women because it is a good thing to talk about. And it is important because many of you have heard awful things about it. Others have heard amazing things about it. And what is it? Is it a good thing or is it a bad thing? And some of you have had great experiences with it, and some of you have had terrible experiences with it. I mean, there's a gamut of what you've heard and what you've experienced. My job is to provide a little bit of light onto this and provide clarity and do my best at that. To the degree I do that, I'm doing a job. To the degree I'm not, let me know. Let me know. When we look at the success of this podcast, Evelyn and I, we don't look at through the lens of product sold, because I don't know if you noticed, I don't sell product. We don't look this through the lens of appointments being set from patients who come from the podcast. We don't do that either, because I'm not soliciting people to become my patient here. I don't even look at the volume of viewers. I'll be honest with you. I really, I know that's important to a lot of people, the amount of followers you have and viewers. That actually is not as important to me. And I'll tell you why. If you have 1 million viewers and only 100,000 of them are getting something of value, it's really the 100,000 I should be talking to. I want to provide something that is of service, that helps, something that where you feel more empowered when you go in the room with your care provider, something where you feel more understood, and you have more understanding. That's the job. To the degree we're doing it, like I said, we're good. If I'm not doing it, hit a comment. Let me know. I always look at Instagram Reels because that's my bias on that, I think. But Facebook, not Facebook. I barely use Facebook. But on YouTube, I'm getting better at looking at the comments. So I will continue improving, getting better on that. So let's get into the material. With that said, why does testosterone matter? My first episode, I kind of went into the highs and lows of it, and like some of the issues around prescribers and the issues that they have, and the history that I have with having used it. But what is it? What does testosterone matter? Why would we want to use it in a woman? First thing I want to tell you is that, and I'm fond of saying this because it's the truth. I'm a man, I'm a guy, and I have estrogen in my body, and I'm supposed to have estrogen. Men without estrogen are not healthy. And men, okay, here's a funny thing. Guys are so weird about hormones. If a man doesn't have estrogen, he can't have an erection. Surprise. That's an important part of male reproduction is estrogen. Man doesn't have estrogen and they try and lift weights, they're going to have a higher chance of their tendon pulling from the bone. They're going to have tendinopathies or even avulsions. Estrogen is an important part of biology and it's great for cholesterol. It does a lot of good things. So estrogen is important for men. So if it's important for me to have estrogen, what about you with testosterone? Testosterone is a very important thing in clinic to me, very, very important. And it is the riskiest thing I do as well because it's the trickiest because it has a higher chance of going in the wrong direction. That doesn't mean we don't do it. That just means I pay a lot of attention to when I do it to not make a mistake. And once I have it that way for you as the patient, safe, very safe. It's on me. This all is on me as your provider to make it safe for you and to show you I did that. So these videos, one of the things I want to convey to you is like, how do you know your doctor's making it safe? How do you keep an eye on that? Are they doing the right things for testing and dosing? Are they watching these things? This is how you keep it safe. Because if you're one of those patients that needs testosterone and we provide it to you and we do a good job, it's life-changing, life-changing. But if I provide it to you, it's life-changing, but I'm not doing a good job managing it or keeping it safe, it's not good because you have this wonderful thing that happens here that you're feeling good with, but it's causing everything to go wrong here. And at some point or another, you have to stop it. So now you lose the benefit of it because it wasn't being well managed. So I want you to know that this is why this is important. Why would I use testosterone in a woman? Why? One of the first indicators is that when you have a lot of estrogen, you're very feminine, a lot of estrogen dominance. Estrogen stimulates tissue to grow. It's very prolific. The progesterone is your primary balancer to your estrogen. It's always the one that helps balance that out. It's going to stop the uterine lining from becoming overstimulated. It's going to prevent the breast tissue. From being overstimulated. It's going to, it's helpful even for adipose body fat. Progesterone plays a role in bringing estrogen stimulation down. but so does testosterone. I see testosterone as a subordinate to progesterone. Progesterone is the primary thing. Right underneath that, we use testosterone. Testosterone modulates estrogen receptors on breast cancer cell lines and inhibits proliferation of those cells. There'll be citation in the notes that you'll see underneath the video. There'll be a little section there in the description. I'll put a citation there explaining that. Do I use it to treat breast cancer? I don't use it to treat active breast cancer. I refer to oncology always. Preventative? Yeah, sure. I'll talk about it as being a preventative therapy. Sure. And then what about post-breast cancer? Abso-freaking-lutely. Testosterone post-breast cancer, estrogen receptor positive, is, in my opinion, and in the literature, essential. I'll say that. And I have oncologists that refer to me and send me patients because it's that helpful. When a woman has breast cancer, what happens? A lot of times, the estrogen receptor positive, they're going to have their estrogen shut down. They're going to be taking medications that inhibit all estrogen in their body. And they're going to now have more issues that are associated with low estrogen. Testosterone helps carry estrogen with a few of these. When you take a woman's estrogen away, she'll inevitably lose bone density. Testosterone in women has been shown to restore bone density, maintain bone density effectively. We use a DEXA scan before and after to prove that. Women who have no estrogen because it's been removed due to, breast cancer, estrogen receptor positive breast cancer, we give them testosterone. Brain chemistry, it plays a big role in brain chemistry. The amygdala, it really affects anxiety because testosterone gets converted as across the blood-brain barrier into androstenediol, and that modulates those GABA receptors. Not as well as progesterone does, but it helps, and it plays a role up there with brain chemistry. Other things about testosterone, and not just in the breast cancer risk factor in that population, you're supposed to have it. Your brain was made to have a little bit of it. And what it does in the brain is, as I mentioned earlier with androstenediol, other things it does in the amygdala is it influences that part of the brain associated with confidence, assertiveness, aggressiveness, risk-taking. This is the part of you that's like that drive that wants to go do things, and the part of you that feels more confident in the face of adversity. Now, it's not perfect. There's no such thing as a perfect, take a pill, you have confidence. It doesn't work that way. But it enhances the biochemistry back in the amygdala that initiates your first response to things. It influences more in that direction. It helps. It's not perfect, but it helps. You have a patient with very, very low testosterone, and you give them testosterone, and you do, sit down with them, a month later, like, how do you feel? How's your mood? You do after a few years, patients will all tell you over time, they felt more confident. They were able to speak their mind a little bit better. They took more risks. Now you're going to say, Brendan, that sounds scary because I'm confidence, assertiveness, aggressiveness, risk-taking. This could be bad. That's true. So I'm going to walk you through this part of it. When we give you hormones, and we're thinking about the amygdala, and we're going to have that impact with these neurosteroids that we're giving you as a hormone, testosterone, again to androstenediol or progesterone to allopregnanolone, these things cross in the brain and have effect. The amygdala is not the final point of emotional decision-making, like the emotional state you're going to be in. The amygdala has to get projected into the frontal cortex. That's where your personality lies. This is where the decision-making part happens. So you feel that aggressiveness. And if you don't really have a frontal cortex, yeah, you'll be aggressive. You'll cut people off on the road. You kind of, weird. But when you give a woman testosterone and she has a healthy frontal cortex, she'll aggressively go after what matters to her. Just by having testosterone doesn't mean you lose empathy at all. It all has to do with the frontal cortex's health. So when you give a woman testosterone, risk-taking, she's going to want to try new things. She's going to step out of her shell a little bit. Boundary setting, that's a part of it too. You'll find more emotional boundaries being set. This is all in the literature. So your response to stressors is different with testosterone. And that's an important part of my practice, important part of what I do. Hormone balance is more than just what's happening down here. This is important, but up here is also important as well. So that impact in the amygdala, I'm aware of, and we watch for that. What about that idea of roid rage, and weird stuff like that? You give someone testosterone, they want to pick fights, and they do weird stuff like that. Testosterone does not do that at all. And And there'll be another citation in below in the description of the video on YouTube, kind of going over why I'm saying this. But let me sum it up for you. The impulse to the amygdala, as I mentioned, it goes up to the frontal cortex, and that's how you find your expression of it. When you are deficient in serotonin and cortisol, you don't have that buffer up here anymore very well. So it tends to push through the frontal cortex. And that's when you see people snap or be more irritable or something going on. Because when you give someone testosterone, it should not cause them to have any of those other symptoms. One of the ways I screen for this, I always run a cortisol with my patients. I always talk about their mental health prior to giving them testosterone. I always get my head wrapped around them. And then I always listen to them after their follow-ups, like, how are you? How are you with this? What are your side effects? What are your benefits? What's going on? Because this is important to keep an eye on, because again, when done right, it's life-changing. But if I don't do a good job, all of a sudden you react to it weird. You have you have the chance of throwing out the baby with the bathwater. We lose the benefit because that side effect was, not good. And instead of managing the side effect, we just got rid of the whole thing. So when it comes to that amygdala, that's an important thing. What else is out there? Like, this is associated with it a little bit, but the fight or flight index in your brain, like, when you have a stress response, trauma response, testosterone's magic with trauma, magic. And there's a journal called Psychoneuroendocrinology that publishes on psychoneuroendocrinology, how your brain and hormones interact with one another and the emotional state that comes from that. And when you give a woman testosterone, there's a few studies that show that it causes her to, it's interesting, I'm going to word it exactly as it says in the journal, but they tend to explore anxiogenic aspects of their environment. In other words, women become more curious about the things that cause anxiety in their lives. And I see it clinically, and it's weird. And if you're a care provider and you've seen this, you'll know what I'm talking about. You put a woman on testosterone, the correct dose, the correct benefit, she feels good, you'll find a change in their mental health. Sometimes they go into therapy. More often than not, they go into therapy, and they find themselves addressing things that have been a trauma in their lives. Because that's one of the things it does. It's a biological effect of it. It's not even intentional. This is just what it does. Another thing is like testosterone, which is weird. When you normalize it, angry faces don't throw you off as much. You don't react to angry faces the same way. It's a strange thing, but in studies it shows that. And just think of it, it's when someone rejects you, you don't collapse. When you face adversity, it doesn't cause you to collapse. Many of you have had a lot of trauma in your lives. Many, many. And if I could be helpful in just that one area, I feel like that's enough. But that's not it. It does all these other things I mentioned. Libido is, I'm taking off my glasses for this part. If any of my patients watch this, they'll concur this is true. I always take my glasses off when I get real. It's like my tell. It's like playing poker. It's like I have like a tell. This is what I'm. You are not performance art. Your libido is intimate and personal, and it's yours. And when we think about libido, it will never be in terms of someone else's satisfaction, because that's not what it was there for. It's yours. And when we treat testosterone with women, we're not trying to ever change her libido for someone else. And you'd be surprised how often you face that as a clinician at work. Women who feel like they need to have a higher libido to please someone. Husbands that send their wife in because fix her. I swear to you, this happens to me, and nothing irritates me more when men do that. When women come in doing that, that's not irritating. That's like, it comes from here. I have a heartfelt like, let's have a conversation about libido with them. Because a lot of times women's libido is more than just testosterone. Almost always is more. Testosterone helps, and it's good. And I want it for you. I want your libido to be healthy. I want your sex life to be a beautiful part of who you are. And it's not just intercourse. Libido is also intimacy and connection. It's that goofy feeling you have when you see that person that's your person. And it's like that, I love that person. It's like that good feeling. I want that. Because that interaction you have with your significant other, there's all these pheromones that occur, and then there's all these neurotransmitters being released, along with that. It's beautiful. It's a beautiful part of your life. So libido is a sacred part of our work. But will testosterone fix libido all the time? Abso-freaking-lutely not. No. Stress is a big part of libido. Intimacy, trust. Yeah, libido is very complicated, and you deserve someone to sit down and understand that with you and care about you through that and walk you through it and try and figure out if there's a biological component or a psychological component. That's your doctor's job, and do their best job to restore that in a healthy way for you. So testosterone, yes, it is very helpful for libido, but I want to make sure you know it's not always perfect, and we need to make sure we have the right goals with it. We can't make you have a higher libido than you're biologically meant to, and we can't give you enough testosterone to overcome the fact that your husband and you or your significant other you guys are having some issues that are worrisome, or you may have had trauma in your past that really impact the way you feel about intimacy. There's a lot of this happens to us, and you can't just say, "Well, I'll just give you testosterone, and that'll get rid of that trauma response," which is not having a libido. It won't work that way. Your body will over-respond in the other direction. So libido is there. It's important, but it's nuanced, very nuanced. What else? Same with libido. Libido gets abused by doctors. You see male doctors or any doctor. And if you have dysfunction as a provider around your understanding of libido and you have an agenda, you will take it out on your patients. And I've seen that. So, you have doctors that just hyperload women with testosterone, and that's just meant to be like, ta-da, look at that's awesome. That's not good, not at all. Same as the next one I'm about to talk about, and that's going to be for lean muscle mass. We know for a fact you will live a longer, healthier, happier life with more muscle mass. Not abnormal more muscle mass, but healthy, normal more muscle mass. That's how did I get this far in life talking like this? I have no clue, no idea sometimes. Let me try and word this better. What's wrong with me? There's the normal range of testosterone that you should have, right? Okay. There's a normal range of muscle mass you should have. That testosterone helps you make that muscle mass. I don't want you to be weird, biologically like supraphysiological muscle mass. That's not healthy. And again, there's a lot of clinics that you'll see, and the care providers themselves look yoked. They're just taking, they're dosing. Whenever your muscles hit a point of hypertrophy that are beyond normal biological levels, that person has dysmorphia, which means they see themselves through a weird lens. And it's like a carnival mirror. They just see their body differently. That they think they're small, and so you kept getting bigger and bigger and bigger. Those guys that become yoked, and they will view the world through that lens as well. And a patient comes in like, well, let me give you more testosterone, and these women will just get big. And that's not what we do either. But we do want muscle mass. I want healthy muscle mass. So testosterone helps with that lean muscle mass, and it does help reduce body fat. And that's one of those parts of the transition through menopause we should be aware of. That's especially important then. It's important throughout your life, but especially important then. So when I give a person with type 1 diabetes testosterone, we have to lower their insulin. We just do. Why? Testosterone enhances glucose uptake. It enhances the action of insulin. What else does it do? It lowers triglycerides. Not every single time. It's not perfect. If you just think I'm taking testosterone, eat what I want, now my triglycerides get better, that will not happen. It will have an impact on someone who's leading a healthy lifestyle. The triglycerides seems to be a little bit out of range. It will bring it in. Not every time, but it's enough to keep aware of that. And that's published in many journals. What else? I know that testosterone helps lower LDL cholesterol. Again, not perfect, but just be aware of that possibility. These are definite benefits to be aware of. Another weird one, I'm just going to say it out loud. When I get testosterone right and thyroid right, I see a really good impact on a patient's growth hormone release. If I measure it through IGF-1, I definitely see an improvement. It's pretty consistent. And growth hormone, I don't want someone to become taller or different. It's just my goal is growth hormone at normal adult levels, it attenuates the degenerative effects of aging. So having adequate levels of testosterone impacting growth hormone can be a good thing too. So we always monitor those things. These are beneficial things from testosterone. In the literature and in practice, as I mentioned earlier, bone density is a big deal with women. big deal. It gets overlooked. And I don't generally like to prescribe, bone building medications rather than use the hormones that help to build bone naturally and normally. Now, if you have a woman who has, estrogen receptor positive cancer, or a woman who does not want to use any estrogen, testosterone will build bone density. It just will. I have good success with that. And you use DEXA scans before and after to verify. As with everything I just said, I want to be sure you know this. It won't work every single time for every single person. That's how medicine is. It's important that we do our lab work to verify we got something and it did the right thing. And then it's important for us to run lab work to verify that it's not causing side effects or downstream metabolites that will lead to side effects. And that's going to be the next episode where I'm going to get into is how do we monitor this? How do we deliver this? How do I make the decisions to take it? Like what are the labs I look for? And how do I do this in a safe, healthy way? And that's our next episode that'll be coming up. So thank you for tuning in. I love doing this. I appreciate you being here with me. I hope this helped. If it didn't, shoot us a message. Otherwise, I'll see you at the next episode.